So kia ora everyone, and welcome to today's Health Psychology Seminar Series via Zoom, hoping that in the future, not so distant future, we'll be able to do this face-to-face again. So thank you for everyone who is joining us today, and thank you for our presenters, Anna and Anna, both presenters.
Oh, yes.
For those, if everyone could mute their microphones if they haven't already, that would be fantastic. Just because it makes it much easier for everyone else to follow what's going on. And as always, this will be recorded, so if anyone would like to access this later, please let me know. I've uploaded them on a private YouTube channel. It's not searchable, but you can access it via a link. Circulate the link if people are interested in circulating this out to a peer as well. I also want to acknowledge it's really lovely to see all the students here who I know are apparently doing it hard, working, like studying from home, although it sounds like some people are quite keen on the idea, but also to some of the clinicians that have come through the program that are working out in the community. It's really nice to see you joining us as well in your busy clinical days too. So without further ado, I'm going to introduce Anna Boggiss, who's a PhD student at the faculty, and halfway through her PhD she tells me she was loving her master's so much she decided to extend it into a PhD. So Anna's going to be presenting her PhD research today, looking at lessons that she's learned from developing a clinically useful self-compassion program for adolescents with type 1 diabetes. So I'll hand over to you, Anna, now.
Thank you. So hi everyone. So as Leisha said, today I'll be talking about the lessons that I've learned about my first year and a half of my PhD in developing a self-compassion program for adolescents with type 1 diabetes, and also those who show disordered eating behaviour, and especially an intervention that, if shown to be effective, could be implemented within a diabetes team with relatively manageable maintenance and monitoring. So I'll start with a little bit of background. As some of you already know, type 1 diabetes is an autoimmune condition where the body attacks against the cells which make insulin. And that's insulin that is needed to keep our blood glucose levels in the normal range, and which, if too high for too long, can damage our bodies over time. And the majority of people with type 1 diabetes are diagnosed in adolescence. So on top of dealing with the difficult changes and challenges being a teenager brings, teenagers with type 1 diabetes also have to deal with learning how to manage a quite demanding chronic health condition. And that's a chronic health condition where having optimal self-management means adherence to quite a complicated routine of daily self-administrations of insulin by either injections or pump, checking and monitoring blood glucose levels, and also correcting those insulin doses for diet, exercise, and any other energy expenditures they have in their day. So it's estimated that they make an average of 180 of these decisions each and every day. And this is even on top of having to learn how to make this quite complex routine fit into their daily life of school, hobbies, and their social lives, all while trying to kind of get that normalcy of being a teenager. So as you would guess, adolescents with type 1 diabetes also show much greater rates of psychological disorders, especially eating disorders, compared to their healthy peers. So adolescents with type 1 diabetes are twice as likely to develop depression compared to healthy peers, and 13 to 21% show clinically significant levels of anxiety during their adolescence. And in a recent large-scale Australian study of adolescents with type 1 diabetes, half of the females who participated and 18% of male adolescents scored over the cutoff for disordered eating behaviour. And this includes disordered eating behaviour that's also related to their diabetes, such as insulin omission or misuse for the purpose of weight loss. And in fact, eating disorders have also been shown to be twice as common in adolescent females with type 1 diabetes compared to their healthy female peers. And rates of disordered eating in adolescents with type 1 diabetes have also been shown to be rising over the last 10 years. And so obviously skipping or misusing insulin and not carb correcting correctly can increase diabetes-related complications and presents as quite a significant challenge for clinicians, especially as rates are rising year after year. And I saw this firsthand on my very first day of recruitment for my first study. A 12-year-old girl came in and thankfully divulged to her endocrinologist that she had stopped taking her insulin because it had made her feel fat. And for her, not feeling fat was more important than the high risk of diabetes complications that the clinicians warn them of, and also the research shows, such as higher risks of diabetic comas, potential nerve damage, vision impairment or loss, heart complications, kidney failure or damage, and even death in some cases. And despite the high prevalence of disordered eating behaviours, with that estimated of half of females with type 1 diabetes especially, and the fact that rates are rising, the treatment options are surprisingly limited. So in Auckland, severe cases are often sent to inpatient eating disorder services. And of course, the diabetes team psychologist is limited in how many patients she can see within a week. And in the research as well, only one study has examined the use of an intervention that specifically targets disordered eating behaviour in adolescents with type 1 diabetes, which was an intensive, family-orientated 6-week education program. And sadly, as we know, interventions like these are really incorporated into standard care long-term, due to funding restraints and also the lack of therapist availability. So how could self-compassion help? So self-compassion, which is treating ourselves with the same kindness and understanding we give our friends, seems to conceptually fit these challenges faced by adolescents with type 1 diabetes, especially to those feelings of self-blame and failure when having difficulties with their self-management, but also body image anxieties, and also their isolation and the feelings of being quite overwhelmed and burnt out from making those 180 decisions every day. So self-compassion offers an alternative way of relating to ourselves when faced with these types of difficult feelings and challenges. And it does this through 3 components. So the first is having this balanced awareness of our thoughts and feelings, which is mindfulness, but also acknowledging that we're not alone in our own suffering and challenges, which is common humanity. And also 3, being caring and understanding towards ourselves, especially in times of difficulty or failure, which is a self-kindness. And as a bit of a side note, the most well-known self-compassion intervention is the 8-week mindful self-compassion program, which many of you are probably familiar with from Anna Serlachius' work in our department. And this program has also been adapted specifically for teenagers by Dr. Karen Bluth, and is called Making Friends with Yourself. So these programs focus primarily on self-compassion, but they also include lots of other positive psychology topics like savouring, gratitude, and values. So we had to decide whether to stick strictly to self-compassion for a brief intervention adaptation, or to include some of these topics. And from Kira Lee's study, also in our department, we knew that her gratitude diary study showed that glycemic control stabilised for those adolescents with type 1 diabetes compared to a waitlist control condition. So before we started, we wanted to conduct a systematic review to see whether gratitude interventions have shown consistent improvements to physical health, to decide whether or not it warranted to be included as a component in our intervention. So we first conducted a systematic review and included 19 gratitude intervention studies. And we found that the most promising overall result was actually for sleep quality, but all other outcome measures such as blood pressure and eating behaviour were all mixed, and all outcomes were relatively understudied. So we decided to charge forth with a really strict focus on solely self-compassion for our brief intervention. And in terms of the research on self-compassion, adults and adolescents who have shown higher levels of self-compassion in cross-sectional research have shown to have less depression and anxiety, as well as stress and self-criticism, less of that maladaptive perfectionism I think most of us have, rumination, shame, and suicidal ideation, but also greater happiness, life satisfaction, and positive age. And in terms of more health psychology outcomes, those who are higher in self-compassion have also been shown to have better health behaviours. So they're more likely to stick to diet and exercise, quit smoking, get enough sleep, have protected sex, and even things like visiting the doctor earlier. And they've also been shown to have better coping and adjustment with chronic health conditions such as HIV, cancer, IBS, arthritis, and even infertility-related distress. And in terms of the research behind self-compassion interventions, although it is quite a new field, most recently the Making Friends with Yourself adolescent self-compassion 8-week program had shown improvements in self-compassion, life satisfaction, and depression for healthy adolescents. And although self-compassion interventions hadn't yet been trialled in adolescents with diabetes or any chronic illness, Anna Boggiss' study showed improvements in mental health and glycemic control in adults with type 1 and 2 diabetes. And most of those improvements were maintained at 3 months, so it was a really promising result. However, we know that an 8-week face-to-face group program is quite logistically and psychologically demanding, especially for adolescents, and may also be difficult to implement in the context of standard care for adolescents with diabetes. So for my first study, we wanted to develop a brief self-compassion intervention and find out whether it was acceptable and also feasible to be delivered to adolescents with type 1 diabetes and those who also show disordered eating behaviour. So we looked at feasibility in terms of the length of recruitment, uptake and attendance. We used qualitative feedback to assess the acceptability of the program, and we also wanted to assess the suitability of outcome measures ahead of a larger RCT, including disordered eating behaviour, self-care behaviours, diabetes-related distress, self-compassion and stress, and also glycemic control as an objective measure. So I approached 168 adolescents in 3 of Auckland's outpatient Starship diabetes clinics, and we had 32 consent. And then once they were consented, all participants were first screened to see if they showed any evidence of moderate disordered eating behaviour to be included in the study. And to assess that, we used the moderate cutoff using the DEXA questionnaire. And this was part of our eligibility criteria to come along to the group sessions. And as a result of our screening, only 5 participants scored under the cutoff and were not eligible to attend the sessions. And we also lost 8 teenagers to sport, school or work commitments, as our sessions were held on Saturday afternoons. And we also had 1 participant move out of Auckland, all afterward randomised participants to groups, which wasn't surprising when we're having to reschedule sessions over the 8 months of our recruitment. And then we started the intervention, and we had 11 in our intervention group and 8 in our waitlist control condition. So in terms of the intervention, I thankfully got to attend the teacher training for the 8-week adolescent program and worked with Karen Bluth to adapt the program from an 8-week program into 2 sessions that were 2.5 hours long and delivered a week apart. And had Kira Lee, who's a registered health psychologist, come along as my co-teacher. And all of these sessions occurred last November. So each session included group activities, exercises and discussions, as well as things like mindful art activities, meditations and individual journaling exercises, all focused on fostering those 3 components of self-compassion, so developing mindfulness, common humanity and understanding that we're not alone in our difficult feelings, and also self-kindness. And thankfully we had amazing involvement from the teenagers who came along to the sessions. So those 19 teenagers had almost an even split in gender and insulin treatment, and on average were 13 years old. And in terms of our results, although we were underpowered to look at statistical differences between and within groups, measures were improving in the right direction. And in terms of feasibility, all of those who attended either 1 or both of the sessions said that they would recommend the program to other adolescents with type 1 diabetes. And 8 of the 10 participants who attended both sessions reported using the tools learnt in the first session in the week between their sessions. And when we look at our qualitative feedback in terms of positive experiences during the program, the most prevalent theme was an increase in coping resources, with 3 of the 19 participants mentioning that the tools had helped them to handle their stress and anxiety. Another prevalent theme was an increased sense of common humanity, so that feeling that we're not alone. And teenagers commonly said their most favourite part of coming on to the sessions was actually just meeting other teenagers with diabetes and knowing that they're not alone in their diabetes struggles, but also the feelings of anxiety and normal teenager things like fighting with parents or siblings or feeling stressed about school. And a more minor theme was that they enjoyed the mindfulness activities and commonly felt really relaxed and focused on what they were doing in the present moment, which were all really encouraging positive experiences to hear. And in terms of suggestions for improvement, only some volunteers offered some improvements. In terms of social aspects, 5 of the 19 teenagers expressed a need for making groups more similar in age, just to be able to allow them to relate more to each other's problems and challenges as they came up. Some participants also expressed that the location was a barrier, with some teenagers travelling as far as 45 minutes each week to attend the sessions. And due to the sessions being 2.5 hours long, some participants expressed the need for even more interactive and practical activities, which was completely understandable in a long session. And lastly, in terms of feasibility, we had a 19% recruitment uptake, and it was possible that the focus on that initial disordered eating screening specifically, and kind of the surrounding stigma may have deterred our uptake. And it also took us 8 months to recruit 27 of our 28 participant target. And also of those 19 who attended the sessions, 9 could only attend one of the sessions due to conflicting commitments with sport, drama productions, study with exams coming up, and also family commitments. So even though we had an intervention that was acceptable to adolescents, it wasn't feasible in delivering it in a face-to-face format for a full RCT. It took us 8 months to recruit those 27 participants, and many couldn't attend both sessions due to other commitments. So we wanted to find out whether the adolescents would want a digital program and what they would want this to look like, which I've found really interesting and I think has lessons for those of us developing digital mental health programs for younger populations especially. So we had a few questions we wanted to answer. We wanted to know what teens want in future digital health mental programs, and also what they disliked about current digital mental health programs or platforms. So we recruited from the participants who consented from our feasibility study, and 19 re-consented to being part of our virtual focus group study that we've held over the time between Auckland's lockdowns, thankfully, over Zoom. And we formed 4 groups that were all quite age similar, with health psychologist Nick Ko co-facilitating a group with Samoan participants and Kiralee helping me facilitate the others. And we showed them examples of existing digital health programs, including a variety of apps, chatbots, and websites. And we used these as prompts to talk about the features that they liked and disliked, and things which they thought would be really helpful or cool additions. And although we haven't formally finished our qualitative analysis just yet, I'm going to present the most prevalent themes we've found so far. So in terms of what they didn't like about digital mental health programs, the most prevalent theme was that they disliked chatbots that they called cringy. So they commonly didn't like the chatbots that made jokes or tried to sound too much like a teenager. And they made really interesting points that you would be the most motivated to use a chatbot when you're having a hard day. And when you're feeling really down and anxious, you don't really want this overly optimistic chatbots sending you jokes, which I think most mental health chatbots do. And one 17-year-old girl, I think, put it really well. She said, you don't want it to be excited in a hard moment with emojis and GIFs. It's so cringy with the jokes too. It needs to help you calm down. And you don't want this super excited person helping you and you're not feeling them, you know, set the mood in very teenager slang. And kind of in the same fashion, they disliked the digital mental health programs that they didn't feel were age appropriate. Both things that were too kind of middle-aged women, but also ones that weren't babied down in the explanations. And one of the participants expressed this as quite a common frustration for her when using these youth mental health programs. So in the quote I put on the screen, she said, you want someone to actually acknowledge that you have the mental capacity that you can actually process what people are saying, like not babied down. And in terms of features they wanted in digital health programs, they've given us quite an extensive list, which has been really helpful. But the biggest and most obvious desired feature that was mentioned by all but 2 participants was some type of social support feature, whether it's a discussion board, live events, or chat rooms. They really wanted just a place where they can share and receive advice with each other and actually meet and become friends with other people with diabetes. And also a place to kind of feel more validated and normalized in the difficulties they face with their diabetes, which they feel like they can't really talk to their healthy friends about. And the second desired feature was having bite-sized tools. So they wanted something they could access really quickly in moments where they were feeling stressed or overwhelmed, that would provide them with a few options and would only take about 3 to 5 minutes of their time. And interestingly, they really wanted a way to check in and reflect on how they've been feeling and how their diabetes self-management is going. So one boy mentioned that he's noticed his mental health is linked to having his diabetes under control. So actually checking in on how he's going and how he's feeling would actually help him take care of himself better. And they also liked that these check-ins helped it to feel a little bit more personal. That kind of taking a moment to check in with them would kind of ease into using a program kind of before overwhelming them with lots of information. And in the same vein, they wanted the program to be able to suggest some tools based on how they're feeling in the moment. So where to next? So even though every group in our focus group voted on a different form of digital intervention, some a chatbot, others an app, the features they wanted to be included were very consistent across groups, and we've decided a chatbot with some type of group discussion, forum or group will best meet the most of their features that were important to them. So for the next year of my PhD, I'll be getting stuck into chatbot development, trying to make a chatbot that regularly checks in on them, suggests bite-sized mindfulness and self-compassion exercises based on how they're feeling, but hopefully one that isn't too cringing or condescending. And I look forward to sharing more lessons learned on finishing my PhD. And before I finish, I'd like to acknowledge my incredible supervisors, Anna and Nathan, and also endocrinologist Paul Hoffman, and also the Starship Diabetes team for their amazing help with recruitment. Karen Blue for her openness in helping me adapt her 8-week program, Kira Lee and Nick for running the focus groups with me, and Kate for helping me with my qualitative feedback. Thank you.
Thank you very much, Anna, for a very interesting presentation from my point of view. Obviously, lots of stuff I'm interested therein. We've got time for one quick question before we move to Anna's talk. If anybody has anything they'd like to ask now or any comments they'd like to offer. Or anyone from any diabetes services who'd like to pitch to use this and implement this in their service? All right, we're all a bit radio silent. What we might do then is we might move on to Anna's presentation, and then if there are any questions at the end, we might hopefully have some time at the end, and those that want to stay can always stay for questions as well. So Anna needs no introduction. Obviously most of you know Anna, and Anna's here today to talk about the Young Fin study and the findings from that. So I'll hand over to you, Anna, and let you jump straight into it.
Great, thank you, Leisha. Okay. Just 1 second. I have many screens open, so thought I'd sorted this out, but just 1 second. Sharing, here we go.
Just we're waiting for our technical issues to be resolved. If you do have any questions and you don't want to interrupt, because obviously it's very hard for the speakers to see everyone, please feel free to post it in the group chat, and we can always ask it at the end, and I can ask it on your behalf or lead back to you. It just helps ensure that we don't miss anybody's questions, that people feel like they can ask it without interrupting.
Strange. Leisha, are you able to share my screen on my behalf?
If you want to send it to me, I think is an
option. Okay, so you can't do that because for some reason it's showing me, because I've got 3 screens open, which is probably not a good idea. So it's not wanting to share the right one. Okay, I've just closed it and opened it again. Hopefully that will solve the problem.
It's IT 101, isn't it? That they
yeah, I know. We even tried it before. I don't know what's going on.
Anna, you are welcome to send it to me, and I can just share from my end if it helps.
Try one more time, and we'll see how we go.
Just while you're doing that, Anna, we have a question from Vanessa Garcia-Hoyas, who is saying, great talk, was wondering if you know of any existing social support programs for adults with type 1 diabetes, for example, those delivered by NGOs or in the community.
Not currently for adults. Anna might have more of an idea. I'm not aware of any for adults.
Sorry, I'm trying to figure this out, but bear with me.
Well, we can.
Sorry for
that.
Vanessa said for adolescents.
Sorry, yeah.
And ADHD and the Starship team, they have, I think it's every 3 months, they have kind of like a support night that the nurses facilitate. And they also have diabetes camps, which are quite popular, and most of the adolescents talked about in the focus group programs. But yeah, they really expressed a need for more regular social support programs.
Mm-hmm. Well, this is looking promising, Anna.
Okay, I think it should work now. Can everyone see my screen?
Here we go. Yep, we've got you.
Oh, my goodness gracious. I've only been using Zoom for practically the whole year now. You'd think I would have figured most of these things out by now. Anyway, here we go. Kia ora koutou. I'm really excited to talk about the Young Finns study, which some of you may have heard me discuss previously, but for those of you who haven't heard me talk about the Young Finns study before, it's one of the largest prospective studies exploring childhood determinants of cardiovascular disease, and increasingly also focusing on other chronic health conditions such as type 2 diabetes. I did my postdoc working with the Young Finns study, and once the borders reopen, I will hopefully be working with them again when I take my sabbatical. I thought I would start by showing you a few photos of Helsinki and Finland, and my brave Kiwi husband moved with me to Finland for 3 years, and I think he was expecting, you know, beautiful images of the sea during the summer and maybe landscapes like this. This is a picture from Lapland, which is in northern Finland. However, the reality, it looks more like this, where 9 months out of the year it's winter. So, but in any case, we survived and we're in Auckland now. So let me just start from the very beginning for those of you who don't know much about the Young Finns study. So, like I said, it's a prospective study looking at childhood determinants of cardiovascular disease. It started back in 1980 and recruited 3,500 Finnish children between the ages of 3 and 18. And here from the cohort profile, you can see that the measures included the traditional risk factors that one would expect, but also a range of psychosocial measures. And this is really what I'm going to be focusing on today. Follow-ups have occurred roughly every 3 years. And I think the other thing that's worth mentioning is it's quite a unique data set because it also includes data from the cohort's parents. And what the Young Finns team is doing now is they're also recruiting the cohort's children. So this is 3 generations of data. For those of you who don't know where Finland is, this is a map of Finland, and also just demonstrating that the cohort were randomly selected from the population register of 5 different regions in Finland. So it is a representative sample. One of the areas that interested me when working on this data set when I was doing a postdoc was exploring the association between protective psychosocial factors and future health outcomes. I wanted to start with this study, as this was a large team effort, because it was for this paper that we built this index of what I'll refer to as a positive childhood environment. We wanted to examine whether having a positive childhood environment would lead to better cardiovascular health outcomes in adulthood. Our outcome measure was the American Heart Association's concept of ideal cardiovascular health, which we measured 27 years after baseline when the cohort were between 30 and 45 years old. For those of you who aren't that familiar with this ideal cardiovascular health concept, you can see here that all of these components were included. So not smoking, having a normal or recommended BMI, doing recommended levels of physical activity, eating a healthy diet, healthy cholesterol levels, healthy blood pressure, and lastly, healthy fasting glucose, which have all been measured in the Young Finns data set. We used both multiple linear regression and logistic regression to predict ideal cardiovascular health, both the index, or looking at all of the components together, and also looking at the individual metrics. What do I mean by positive childhood? Well, this index that we built was really based on existing literature, which for those of you who work in this area know that this literature has predominantly looked at negative factors in childhood. So we comprised this positive index looking at these 6 different categories. Socioeconomic factors is pretty self-explanatory. Emotional environment are things like absence of parental mental illness, looking at parental life satisfaction. Stability is around things like lack of stressful events like parental divorce or separation, death of a family member, serious disease, things like this. Health behaviors was parental health behaviors, so things like smoking, physical activity, parental BMI. Self-regulation was the child's self-regulation, so being able to control impulses, control aggression, and things like this. And finally, social adaptation was the parent's evaluation of the child's sort of general level of adjustment. And also, if you ever wondered what a Finnish beach looks like, there's your answer, and quite different from New Zealand. And my poor kids even have to wear wetsuits in the summer. I'm going to jump right into the results. So our key finding was this quite striking dose response pattern in which ideal cardiovascular health increases according to rising levels of favorable psychosocial factors. Those with more positive childhoods had a 14% greater chance of being normal weight in adulthood, 12% greater chance of being a non-smoker, and an 11% greater chance of having healthy glucose levels. So when you look at those odds ratios, they're quite high for being psychosocial risk factors, and you know, they're sort of the same magnitude as many traditional risk factors of cardiovascular disease. In the fully adjusted model, you can see that the family's socioeconomic status and also the child's self-regulation remained significant predictors of ideal cardiovascular health in adulthood. Bearing in mind, this model is also adjusting for things like age, sex, childhood cardiovascular disease risk factors, so like BMI, blood pressure, and it's also adjusting for adulthood medication. What did we find from this paper? Well, obviously that positive early experiences appear to have cardiovascular health benefits. But what was interesting is that it seems to have cardiovascular health benefits for all people. And what I mean by this is an improvement in one aspect of this positive childhood index had measurable benefits. So for example, maybe a parent quitting smoking or getting an unemployed parent back to work increased the benefits or in terms of having more ideal cardiovascular health in adulthood. Early life stages are important in cardiac prevention efforts. This is now well shown in the literature, and that building on psychosocial strengths can be a step toward good cardiovascular health throughout life. After this study, we also went on to see if a positive psychosocial environment protects against future risk of type 2 diabetes. We're able to look at things like type 2 diabetes and also prediabetes now in the young infants cohort, because of course these things increase with age. And so there are now enough people in the young infants data set that we can look at things like diabetes as well. I'm again going to jump straight into the results, and similar to the circulation paper, we found that those with positive childhoods had lower risk of disease. And here you can see that with each one standard deviation increase in the positive psychosocial score, you had a 21% decrease in the rate of type 2 diabetes and an 8% decrease in the rate of prediabetes. I wanted to show this, this model as well, because growth curve modeling is quite neat because it captures growth for the group and both for the group and for individuals over time. So this is showing a growth curve of glucose levels in quartiles of the total positive psychosocial score in childhood. So this figure depicts this interaction, showing healthier glucose trajectories for participants with a higher versus lower level of positive psychosocial score, which you can see here. So this trajectory here is, of course, showing a lower kind of increase in glucose levels, which is what you would like to see. What did we find with this study? We found that having a broad set of positive psychosocial factors in childhood was associated with healthier BMI in adulthood and healthier glucose trajectories. And I didn't now touch on the mediation analyses we did, but these were in fact mediated through BMI. There are also, of course, other possible mediators. A lot of literature has suggested that positive psychosocial environments might have favorable effects on biological stress regulatory systems and things like that. And I'll touch on that in a moment. But in this particular study, we just looked at BMI as a mediator. And finally, that child psychosocial factors play a role in the development of diabetes. In some of my previous talks, in the seminar series, I've discussed how other positive psychosocial factors, such as, for example, social support or optimism, also seem to protect against future chronic health conditions. I'm not going to go into these studies in detail today, because I thought what would be quite interesting to do instead is to think about why. So why does social support protect against, for example, future risk of obesity? Or why does social support protect or buffer against prediabetes? Or alternatively, why does high optimism protect against high BMI? One of the best models that I've come across to help answer these questions is this one, proposed by Julia Bohm and Laura Kubzanski at Harvard. And this model that I'm going to show you in a moment was developed based on the literature surrounding psychosocial factors in cardiovascular disease, which is much larger than the literature in other areas, for example, looking at diabetes or other health conditions. And this literature, again, started by looking at many negative psychological factors, such as depression, but has now moved on to looking also at positive psychosocial factors. This is the model. And what basically this model is proposing is that, hopefully you can see my mouse here, is that the underlying pathways mediating the association between positive psychological well-being and health are health behaviors or biological functioning, which of course makes a lot of sense. And so what this model is proposing is that positive psychological factors increase what the authors call restorative processes. So these are things like eating a healthy diet, taking part in more physical activity, and the positive psychological well-being also reduces what they call deteriorative processes. So for example, inflammation. There's also this association with stress. So positive psychological well-being decreases stress. And of course, we know that high stress is associated with inflammation and more wear and tear on the body. So if we bring this back to the Young Finns study, what I sort of like to use this model for is to try and explain some of the findings that we found around positive psychological factors early in life, and how positive psychological factors early in life might increase these restorative processes, such as eating a healthy diet, having more exercise, and reduce these deteriorative processes, and also reduce stress. And what's quite interesting is that a lot of the mediational studies that we've done using the Young Finns studies, the Young Finns data, has found that these pathways do in fact mediate this relationship. So some of the work that I've done has looked at, for example, optimism and how health behaviors mediate the relationship between higher optimism and better health outcomes. Just checking the time. Okay, so okay. In some more recent work that I've done in Auckland with one of my previous students, Kira Lee, who Anna also mentioned earlier, and also with Nathan, we've gone on to amend this model to include other positive psychosocial factors like gratitude. You can see here we've included gratitude up here as a positive psychological factor, and we've also included social support, which is missing from the original model. And I think social support is an important one because, of course, there's a huge literature around social support and its impact on health. And so I think adding social support here makes a lot of sense, and that social support would also increase these restorative processes and reduce these deteriorative processes. And we've seen that again in the Young Finns study with, for example, something like optimism, which we know is associated with higher social support. And we've also seen that social support is linked with higher or more healthy behaviors, such as, in particular, things like higher physical activity. So what are the lessons learned from the Young Finns study that I can share with you today? I think the primary one is that the childhood environment has long-term health implications. I've talked about a lot of these psychosocial factors, or psychosocial strengths, if you like, as modifiable. But I think it's really important to emphasize that they can't replace factors like financial security, secure housing, good schools, free and accessible healthcare. And so we all know that it's much harder to build on psychosocial strengths if you come from a single income household, or have a parent with mental health issues, or worried about paying for rent, or whatever it might be. So I'm not suggesting that interventions that just focus on these psychosocial factors are the answer. I'm saying that in terms of intervention development, this needs to be alongside improvements in social policy. And I think the most direct way to improve positive childhood factors is through social policy. And that's really investing in the well-being of children and families. So I'm going to leave it there if anyone has any questions.
Any questions from the audience? I'll give you a few moments to type them out as you formulate them. Of course, you can ask them, so just feel free to call out as well now that Anna and Anna has finished. So questions for either would be welcome. Very quiet lot, aren't they, at the moment?
I've got one in the chat. Just wondering if you know of any existing social support programs for adults with type 1 diabetes. Ooh, that's a great question. Oh, sorry, not adults, I meant adolescents. Well, the ones that I know of are through Facebook. So there's a few Facebook social support groups. Actually, the one I'm thinking of is for young adults, not especially for adolescents. So I'm not sure if there is a Facebook one which is targeting adolescents, but I think the young adults one also is meant for adolescents. And then, of course, there's what most adolescents with type 1 diabetes, where they get most of their social support, is through these diabetes camps, which I'm sure anyone who works in the diabetes space knows about. And those diabetes camps are usually organized through the diabetes teams. And I know that Starship helps to organize those as well.
It's really interesting, isn't it, that, you know, social support is such a key area of our well-being, and in adolescents particularly, there's so much emphasis placed on the connection with friends and peers, and the, you know, developmentally individuating from adults, and peers are so much more important. And yet we really do seem to have this lack of support groups available. And I think there's, you know, a number of reasons that often there's concern around how you manage relationships in those groups, and, you know, what if things become difficult, but actually young people are pretty good at managing that stuff. And so,
yeah, yeah, absolutely. And, you know, it's interesting with Anna's chatbot study, how one of the key things that also many of all, you know, the previous work that I've done has shown is that they want to connect with others. And that's, I think, one of the biggest challenges with digital health interventions, is kind of ensuring that you make that connection possible.
Anna, you have another question there from Olivia.
So I'm just making sure this is for me, not for the other Anna. It's getting very confusing.
Yes, that's for you, Anna.
This is for me, okay.
Yeah.
All right, are you aware of interventions advice you would give an adult with obesity after explaining the links between adverse childhood experiences and higher BMI? Oh, that's a tricky one. Yeah, that's a really tricky one, because like I said, you know, a lot of these factors are out of the individual's control. Of course, if you grew up in a family who comes from a lower socioeconomic background, or had more adversity as a child, these are completely out of your control. So I probably would then focus on the things that they have control over, and not necessarily, I mean, it's of course, if you, you know, I don't know if we need to kind of focus too much on explaining to them the kind of increased risk, but rather focus on the things that they can do. And most of those psychosocial strengths, as I explained, are modifiable. So I would, you know, make them aware of the fact that, you know, things like, you know, looking at increasing your social support through, for example, joining the gym, or joining sports teams, or doing very simple exercises to improve things like optimism or gratitude, have demonstrated quite a lot of really interesting effects also, not just on mental health, but increasingly also on physical health outcomes. So I would sort of focus the conversation along those lines.
Thank you, it's very helpful.
Thanks, Olivia. Any other questions? Okay, well, we might leave it there. Thank you, Anna and Anna, both for some really interesting topics today, and presentations, and great presentations, and definitely some things for people to think about, particularly looking forward for ongoing research and potential PhDs as well. Really appreciate you presenting today. Like I said, for everyone else, hopefully we'll be back to face-to-face soon, so keep an eye out for the links. And the recordings for these are available, so if you'd like to access the recordings, or someone would like to access it who isn't here, please let me know and I'll be able to send you the link to that. Well, thank you very much, everyone, and if there's no further questions, then we'll end the Zoom.
Great, thank you, Alicia.
Thanks, Anna. Thanks, Anna.
Thank you.